In this video, we'll discuss about inflammatory bowel disease IBD. IBD is a chronic condition resulting from inappropriate mucosal immune activation. So it is a chronic condition which occur because of inappropriate mucosal immune activation. It consists of two diseases. Inflammatory bowel disease consists of two diseases, Crohn disease and ulcerative colitis. Ulcerative colitis. So what is the epidemiology? Age, it affected mainly teens and early 20s. Then sex, and comparing to male, female more affected. Hygiene hypothesis. It says that improved food storage condition and decreased food contamination result in alteration of mucosal microbiota. This is the one of the hypothesis proposed by many of the investigators. Then pathogenesis. First one is genetics. In genetics, we have NOD2 gene. NOD2 gene, nucleotide oligomerization domain 2. Then ATG16L1, autophagy related 16 like 1. Then IRGM, immunity related GTPase family G protein. These two, ATG and IRGM, these two are related with autophagy. Then NOD2 gene, this one, whenever that alteration or NOT gene which result in activation, NOD2 gene mutation or alteration activation of nuclear factor kappa and lambda pathway. This result in accumulation of lot of mucoside. So activation of kappa and lambda pathway result in accumulation of lot of mucoside. Next, pathogenesis. This is the lumen side. This is the epithelium lining. Lumen side epithelium lining. Between epithelium there have a tight junction. Whenever there is barrier defect, so here barrier defect result in flux of bacterium. Bacterium will come inside. The bacterium is the normal component. The bacteria get invade as soon as bacteria enter antigen presenting cell, that is the dendritic cell, present antigen to the CD4 plus T helper cell. The CD4 plus T helper cell get differentiate into CD4 plus T helper 1, CD4 plus T helper 2, CD4 plus T helper 17. This T helper 1 cell produced interferon gamma which result in activation of macrophages and it start to producing tumor necrosis factor. This factor result in inflammatory changes and it acts the bacterial component of our own epithelium. Second, the T helper, the CD4 and T helper 2 cells which produced interleukin 3 which also do that same function. Then T helper cell 17 which produce interleukin 17 which call the neutrophil. This one will call the neutrophil for the site of inflammation. Inflammatory epithelial cells also produced interleukin 8 which called the neutrophil. So basically there is epithelial defect. So here because of epithelial defect bacteria enter that component antigen presenting cell. So antigen presenting cell to the CD4 and T helper cell, maturation of T helper cells into CD4 T helper cell 1, 2 and 17 produced interferon gamma, then interleukin 3 and interleukin 17 and inflammatory changes. This is the one of that model of inflammatory bowel disease pathogenesis. So this is the one of the pathogenesis. Now inflammatory bowel disease, first disease name is called as Crohn disease. In Crohn disease, involved in small intestine as well as large intestine. In this one, ascending colon, transverse colon, then descending colon, then sigmoid colon and rectum, all the part affected. So the green color one, infected area, skip lesion, multiple small and sharp lesion. So Crohn disease also known as regional enteritis. Enteritis. So like this one is the diseased one. Like this means normal one. Like this means this one is the diseased one. So diseased one. Changes in Crohn disease. What are the changes we can find out? That conjunction. So we can find out conjunction. Then T transmural ulcer, or here we can find out a transmural ulcer or knife like ulcer. Then inflammatory changes we can find out. Then here creeping fat we can find out. So changes in Crohn disease, conjunction, deep or transmural ulcer or knife like ulcer, inflammatory changes, creeping fat we can identify. So mucosa, submucosa, then normally all the things in this one, these are the four changes we can identify. So next one is microscopic changes. First one is mural, all the thickness of that wall involved. So mural means all the thickness of wall involved. Transmural can seen. Then crypt abscess can be seen. Crypt abscess, this one is the crypt abscess. Any tubular, this one, any tubular can presented below that epithelium, that one is the crypt abscess. Then mononucleus is presented, mononucleus and a granuloma. So this one mucosa, submucosa, muscaris furfura and serosova. In this one microscopic changes transmural followed by crypt abscess, then mononuclear and granuloma formation. So in granuloma, Langerhans type of giant cells also find out. Here we can find out giant cell. So this is the microscopic changes of inflammatory bowel disease, Crohn disease. Clinical features of Crohn disease: mild diarrhea, fever, abdominal pain, fat and vitamin malabsorption, malignant potential, lymphoma more predominant and comparing to carcinoma, then pericholangitis, sclerocholangitis, also seen, fistula formation, perforation, peritoneal abscess, fistula formation and perforation, peritoneal abscess, these are the things complication. Second one is ulcerative colitis, also known as pancolitis or ulcerative proctitis or ulcerative proctosigmoiditis. So infected area acceleration loss can be seen by this Bernium meal X-ray. So here all over ascending colon involved, that is continuous colonic involvement. There is loss of acceleration. Loss means here like this presented normal area, infected area, that acceleration is missing like state. So this one name is called as lead pipe appearance. So this one name is called as lead pipe appearance in Bernium meal X-ray. We can find out lead pipe appearance. Bernium meal X-ray. Superficial ulcer can also seen, and in ulcerative colitis this one began with the rectum. So in this one superficial ulcer also seen, it began with the rectum and progresses forward. It never exceed beyond that colon. only the transverse colon only. Here it will affected transverse colon. Unlike Crohn disease involved in both ileum as well as colon. Ileum as well as colon will affected. Here this one not exceeded transverse colon. So here only this part only affected. Superficial ulcer can be seen. Ulcerative colitis begin with that rectum, progresses forward, never exceeded this colon, that transverse colon. Then when we take transverse section, this one is the transverse section of it, we can see ulcer. So we can see here ulcer. This ulcer make normal mucosa look like polyps. It look like polyps, so this one name is called as pseudo polyps. Microscopically, and ulcer seen in mucosa and submucosa. Then crypt abscess also seen. Epithelium lined by goblet cells. So epithelium lined by goblet cells. In this one, that goblet cell are decreasing in that ulcerative region. Inflammatory changes like neutrophil, that inflammatory cells, neutrophil are seen. Then blood vessels also seen. So this is all about ulcerative colitis in microscopic appearance. What are the clinical feature? Bloody diarrhea, lower abdominal pain, a cramp or temporarily relieved by defecation. Then toxic megacolon, then perforation and malignant potential. Carcinoma more comparing to lymphoma. These are the complication: toxic megacolon, perforation and malignant potential. Last one is difference between Crohn and ulcerative colitis. Crohn disease and ulcerative colitis. First one is cross site. It will affect ileum and colon. This one only colon part. Then distribution. This one is the skip lesion. This one is diffuse. Then that copal stone appearance present here, absent here. Creeping present here, absent here. Wall thick, wall appearance here thick. In Crohn disease thick, and ulcerative colitis is thin. Then microscopic appearance, inflammation transmural. This one limited to mucosa. Ulcer here, deep knife-like ulcer. Here two superficial broad based ulcer. Then granuloma presented, absent. Then lymphoid reaction marked here, moderate. Then pseudo polyps moderate, marked. Then serositis marked, mild to none. Then clinical features, fat and vitamin malabsorption present, absent. Then next one is malignant potential. Lymphoma predominant and comparing to carcinoma. Here carcinoma predominant comparing to lymphoma. Perianal fistula formation positive, here negative. Then recurrence after surgery, common, not common. Toxic megacolon, absent, present. Then pericholangitis, sclerosing cholangitis, more, here less. So this is all about inflammatory bowel disease, Crohn disease and ulcerative colitis. So this one is a skip lesion. This one is the skip lesion. This one is the pathogenesis. Inflammatory bowel disease, Crohn and ulcerative colitis. Thanks for watching.